This is a subject that I'm not an expert in, but I'm kind of in the middle of as part of my work with Central DuPage Hospital. So I'm going to cover some thoughts, but before I do, I thought I'd read from a classic in healthcare. The title of it is "Who Shall Live?" This was required reading for officers at Service Master because we were serving in over 1,500 hospitals here across the United States and also hospitals in another 30 countries. We did such exciting things as housekeeping, plant operation and maintenance, food service, those kinds of really exciting things. But if they're not working in a hospital, nobody's happy. So, but we had a lot of involvement with healthcare as a company. This is written by Victor Fuchs, and listen to what he said as he began his book about healthcare. The title again is "Who Shall Live?" In recent years, almost every American family has become acutely aware of the soaring costs of medical care, the difficulties of access, and the mounting health problems of our society. According to many observers, the U.S. healthcare system is in crisis. Now, this is the way he ends the book after he discusses that subject. At present, he says, rising costs are the forcing factor for political action. Significant compromises are likely in order to overcome the objections of specific interest groups. Some compromises will probably tend to increase spending while leaving organization and delivery unchanged. The time is past for either superficial measures or just pouring more money into the present system. That was written in 1974. What has changed in over 35 years? Well, in 1974, Americans were spending $450 per person in health care. The total bill represented 8% of our GNP. Now, 35 years later, healthcare costs represent 17% of our gross national product. We are spending on average $8,000 per U.S. resident, expected to increase to $13,000 by 2018, and to be 20% of our GNP. Medicare and Medicaid, put them together, now account for 20% of all of our federal spending, projected to be 40% by 2018. Estimates are now that people retiring now will need over $500,000 to cover their health care costs in retirement that will not be covered by Medicare. In 2007, over half of the bankruptcies filed in this country were caused by people who could not pay their medical expenses. Interesting. Projected levels of expenditures from the Medicare Trust Fund is expected to be depleted by 2018. As a percent of GNP, U.S. spends far more than other developed countries. Most recent statistics show Canada is about 10% of GNP, France 11%, Germany 10.5%, Japan a little over 8%, UK 8.5%, Switzerland a little over 11%. Over the past 10 years, insurance premiums in the United States have grown over 120%. Inflation over the same period has been 29%. Wages growth has been 34%. So, a lot of statistics. We spend more, and what do we get for it? The most recent and complete study on this subject was done 6 years ago. So these are some old statistics I'm going to give you, but it was the most complete study that was done. It indicated that in several areas we do spend more, and on average we're getting less. U.S. was the third highest in deaths from medical errors. U.S. was the third highest in infant mortality. It was below average, that is, 22 countries were ahead of us in life expectancy. Now, as I quote those three categories, let me just say that, first of all, I'm talking about averages. And you've all heard about the man who walked through the river with an average depth of 5 feet and drowned. So averages themselves can be deceiving, and part of the issue in averages in our country is typically we have greater disparities in this country than in many of the other developed countries that are being measured. Also, there's a problem with definitions. In most of these countries, premature births are not counted as part of the death of infant mortality. So if you exclude them, which is the highest risk category, you'll be coming up with some different statistics. We include them in our count. There's also a problem in the way we live. U.S. residents consume more sugar and more calories than anywhere else in the developed world. 2 out of 3 Americans are overweight. 1 of 3 are obese. 75% of all healthcare costs are spent on patients with 1 or more chronic diseases: diabetes, obesity, heart disease, high blood pressure, and lung disease. Now, there's another factor here as we are looking at these percentages and outcomes. And I'll be giving you a case example of it here before I finish. But America's advances in medical technology and innovations, devices, drugs, IT, procedures, cost more, enable treatment of more acute situations than in other places of the world, allow for quicker recovery, which, by the way, we don't measure. The fact that so many procedures today are done on an outpatient basis, and people are back to work in a day or 2 days. We don't measure the productivity factor from the high cost. We just measure the high cost. They allow for quicker recovery, less discomfort in the treatment, but do not affect major outcomes like life expectancy. But all of those elements, all of those, quote, quality elements are there in significant dimensions in the delivery of health care that are not there in many other countries. As I indicated, in our business and service master, we were serving all over the world. So one of the things I had an opportunity to do was observe the delivery of health care in Japan and China, in the Philippines, in the UK, in Europe, countries in Europe, in the Mideast. You know, I just had kind of one understanding with the folks that I traveled with. And it was simply, if I get sick, the first thing you do is get me in a plane and send me home. There was just nothing I saw that compared with the level of health care we have here, with all of those ingredients that I just mentioned. But that said, our costs and our outcomes are a problem. The second area is unacceptable coverage gaps. Is that a question of access, or is it a question of coverage? Today, in the United States, every hospital has to accept anyone that comes to them. It usually ends up, if they are not covered by insurance, coming to the emergency room needing care. All different types of care come to our emergency room in Central DuPage Hospital, but nobody is turned away. Not only would we not turn away people, legally we cannot turn away. Doctors can make choices as to who they treat. Hospitals cannot. So there is already a scope of care. Not very satisfactory. I'm not saying it is acceptable, but there's already a scope of care for everyone. And by the way, most hospitals do not differentiate as to whether or not you are a documented citizen, which the new health care bill does make a differentiation. So we do have some access, but we have big gaps in coverage. 85% of Americans are covered by some form of health insurance. 60% from employers, 10% individually, 30% government funded, and that would be primarily our Medicaid and Medicare programs. But there are 40 to 50 million people uncovered by insurance in the U.S. Of that 40 to 50, somewhere, and of course you can't get accurate statistics on this, 10 to 15 million undocumented. Some would say illegals in that 40 to 50 million category. Now, one of the dilemmas is that there's a difference in pricing in health care, and I've got Jim Spear in the back of the room, who is our Chief Financial Officer at CDH. I've got to be careful when I start covering some of these things, but retail and wholesale. Insurance companies, if you're insured and you come to a hospital or to a doctor, your insurance coverage, the insurance provider has already worked out an arrangement with that healthcare provider. So they do not pay, the insurance company does not pay retail. The discounts can be as great as 50%, some cases maybe 60% off the retail price. Medicare doesn't pay retail. Medicare and Medicaid, the discount is 80%. There isn't any hospital I know of that is having any profit on Medicare patients. They're all losing money on Medicare patients. Now we get into cost shifting a little later. But the person who pays retail, or could potentially pay retail, is the working poor who are not covered. The local owner of the gas station, young, he's got a young family. He doesn't think he can afford health care insurance. Young children. He could borrow money if something really happened, he says. And so something happens to one of his kids, requires extensive care. He could pay retail. Not those discounts, but retail. Now, if he knew about all the discounts, he might start negotiating, and I'm sure the hospital would negotiate. But there is a retail price, and he could easily pay that retail price. Plus, he would pay for it in after-tax dollars. when all of us who are covered by insurance, by our employer, we have a great benefit. None of us are taxed on that. The government loses money on that. And they doubly lose money if we work for a for-profit entity, because that for-profit entity takes a deduction in the taxes they pay for that cost that they cover. Meanwhile, this poor person over here, this working poor person, doesn't get any of those advantages. An unjust result, in my judgment. But that can happen in our system. That tells you some of the quirks in our present system. A quirk, by the way, that isn't fully resolved in the new bill. Looking at CDH as an example, 8 years ago, our cost of what we call charity care, covering care where people can't afford to pay for it, was about $10 million. This last year, it was $65 million. We have a program in DuPage County called Access DuPage, which is for people who do not have the resources to pay for health care. There are 5, 6 hospitals in DuPage County, I think. Central DuPage has over 50% of Access DuPage. Now we could get into all discussion why that's happening, but it is happening. So when we get finished with this whole issue of unacceptable cost and outcomes, unacceptable coverage gaps, what should be our position as a country? Is health care a right that everyone should have? You know, we've determined a long time ago that an education component in this country is a right. That's why we have public education up through high school, because we've said it's a right. We'll pay for it, even if you don't have the money to pay for it. Is health care that kind of a right? And then how should we respond if it is? Is it a right just for Americans? Or is it a right for anybody who's here? If you were in England today and you got sick and you went to the hospital, they wouldn't ask you whether you were English or not. They wouldn't ask for your license or your passport. They would treat you. We're still not ready to do that, even in the new health care bill. And if we're going to treat everybody, and if it's a right, at what level do we treat them? Is there a gradation that we'll accept? Is there a Chevy, and is there a Cadillac? Or is there only one health care? That's the only fair and just way to do it. We all know what's happened to our education system. Education in the inner city today is totally different than education in the suburbs as to the quality of education. We kind of just don't like it, but we accept it. Will we accept that in healthcare? Those are some of the policy issues that are before us as a country, I think. The third aspect about healthcare today, now this is all pre-Obamacare, is we have a fragmented and very inefficient delivery system. We have a misaligned payment system. We have a fee-for-service payment system, which basically rewards providers on the amount of care they deliver, not on the quality of the result or the outcome achieved, and can lead very easily to overutilization. a failure to establish effective and efficient protocol standards for uniform diagnostic and treatment of medical care. We still accept that the practice of medicine is an art. We still allow for highly individualistic decision-making and judgment. We have a system where if you practice medicine today, you would have a fear of litigation. We're desperately in need of tort reform. We have experiences, we have models out there that show that a more efficient system can be delivered. One of those models is one of our partners at CDH, it's Cleveland Clinic. In heart and cardiology, Cleveland Clinic for the past 17 years has been rated #1 in the country in outcomes. In that discipline, they have one of the lowest costs of discharge in the country. 15% below the national average. That's the big measurement for the end of care and cost and whether your cost is correct. How do they do it? How are they #1 in outcomes with a reduced cost like that? All the physicians are employed by the hospital. They have developed scientifically protocols that lead to those outcomes. And those protocols are followed. There is a disciplined, managed system of following the protocols on a rigid basis. Not much discretion. And well, we'll test it and see. We'll run them through this test first. It works in Cleveland Clinic. Would it work if it was in a bureaucratic government system? I don't know. I kind of shudder to think about it. But it's a model that works. It's a model that people are looking at, as trying to understand how can it be replicated in the same efficient and effective way. Then there are these influences of hidden costs. The cost shifting that I referred to, the subsidy of Medicare and Medicaid. So every one of us that are privileged to be on insurance plans are being taxed in those plans for Medicare already. We are participating in the subsidy of Medicare. And yet Medicare is running out of money because the discount rate is so high as to what they reimburse providers for. In fact, response to some of the suggested changes last year, you had doctor groups saying they would refuse to take any more Medicare patients. You even had a Mayo Clinic in Arizona making that decision. The doctors can make that decision. Hospitals cannot. They have to accept whatever patient comes to them. So that mix means that everybody pays more. And let me just tell you that if a hospital starts moving above a 50% mix in Medicare patients versus private patients, they are, in fact, in the process of going bankrupt. They're losing money on every Medicare patient. So if they don't have a higher than a 50% mix of private pay insurance, they don't have the offsetting cost shifting. That's a reality in our system today. There's a growing shortage of primary care physicians, estimated to be growing to the point of over 65,000 needed primary care physicians, above and beyond what we have by 2025. There's an inherent lack of economy of scale in the delivery of health care today. 45% of physicians still practice solo or in groups of less than 5 physicians. Only 4% of the physicians practice in groups of 50 or more. Hospital beds today are wasting assets because of the increasing outpatient ability for care. So, those are some of the issues in a fragmented, inefficient delivery system. So let's now take a look at how Obamacare is responding to these things, or whether they are ignoring that factor, or what's happening. Well, first of all, for those of you that have read about the bill, you know that it comes in place in stages. And I'm going to just give you some summaries now of those stages. From today, or from 2010 when it was passed, to 2014, we have a bunch of rules and regulations affecting existing insurance companies. That's probably the most major factor that's happening. Eliminating pre-existing conditions, eliminating lifetime benefit maximums, mandating certain preventive care, setting medical loss ratios, limiting profit returns, reducing profit margins. All of those are primarily impositions on existing insurance providers. There's also, however, a funding to pilot, test new ways of delivery. Some they call bundled payments. In other words, where the reimbursement agency, whether it was an insurance company or whether it was the government, to a hospital, let's say, for a particular process or disease, would say, here, we'll pay you X dollars, you pay the doctor, you pay everything, but we're just going to make one payment. They're going to test that method as a way of controlling costs. Again, it's a payment method of controlling costs rather than enforcing some innovation in delivery, rather than introducing the changes in delivery. Another group that's going to be tested is what is called accountable care organizations. And I'll talk a little bit about those as models. In 2014, we get the beginning of the coverage of the 30 million people, primarily through mandated insurance. That's the big issue that's being tested now in the court systems as to whether it's constitutional and legal. Creating state-based insurance exchanges, federal subsidies for low-income folks. And this is where we're also going to get the new tax and expanded tax for Medicare on passive incomes, dividends, and other types of incomes. Expansion of the Medicaid programs to cover up to 133% of federal poverty levels. 2017 to 2020, we'll have federal financing of Medicaid packages being reduced. States will be responsible for the difference. And we have the new excise tax on what's referred to as Cadillac plans. Beginning next year, W-2s, the tax form that shows how much you earn if you're working, will have a new category. It'll show the value of your health care benefit. You won't be taxed on it, but people will start recording it. And if it's over a certain dollar limit by 2018, you will be taxed on it. So the reform bill, first of all, is a bill that focuses primarily on insurance reform and has the coverage expansion to the 30 million people. It stops short of any full-fledged health care cost reform or economic reform. However, as I mentioned, it will increase, certainly, utilization, because there'll be 30 million more people that will have access to the service with some type of payment method. The real question is at what rate? If it's a level of Medicare, dumping the extra people at Medicare where people are already losing money is not going to help the system unless the system changes. There's an additional mandate given to the Secretary of Health and Human Services to develop and enact what they call transformative healthcare delivery and financing models. So this is where the accountable care organization model fits in, bundled payments. Actually, some of what the Health and Human Services are directed to do are already going on in the private sector today. Advocate Healthcare, for example, locally recently signed a contract with Blue Cross Blue Shield in which its hospitals will take accountability for managing the health care spending of all of its patient populations. Geisinger Healthcare out in Pennsylvania has initiated a single payment for all services related to the treatment of a specific condition. That payment includes a warranty that covers preventive complications in the event of readmission. Very interesting payment method. Geyser Permanente is probably one of the best examples of accountable care organization. It now manages the lives of 8.6 million people through a network of 35 hospitals, 431 outpatient facilities, 14,000 physicians in its employ. Permanente's medical group physicians have just accepted a capitated payment plan exclusively for its plan members, the Kaiser plan members. The impact of other key provisions of the bill is not yet clear. What's going to be the rate of conversion to state-based insurance exchanges? How many major employers will be granted exceptions to the coverage requirements or opt out entirely? All those issues are still issues. So in summary, the bill that was repealed by the House recently is basically an insurance model, but does not deal with an efficient and effective way of reducing costs, coverage, or providing quality care. Healthcare itself is a consumer of capital. CDH, over the last 8 years, will be spending $1 billion in capital to serve this community. Now, there's many things we've done as part of that investment of capital. But healthcare is a consumer of capital. There's nothing in the discussions, there's nothing in the bill about where the future capital is going to come from. And if you can't deliver the service and earn a surplus, you won't have a source of capital. No one was taxed in DuPage County for the $1 billion we've spent in the last 8 years. It's because we've delivered health care and generated a surplus for the capital. There's only one other source, and that's the government. And the government, we can only have a source if they tax it or a deficit grows. So capital is essential for the delivery of health care, and nothing is said in any of these models or in any of these provisions for expanded coverage or for it to be done through an insurance model of where the resources are going to come for capital. And I suggest that the Department of Health and Human Services is not the vehicle to study innovative care. We've had now almost 50 years of that area of our government managing Medicare, and what do we have? A bankrupt system with not a lot of innovation in it as far as delivery. So I think there's more to do. Our president suggested last night that this is an opportunity to work together. as far as government is concerned, to come up with something since an initiative has been made in the House to repeal what was done. What should we be done? I've already indicated that we've got some issues. Our costs are too high. We've got gaps that are unacceptable, that we've got to do something about coverage. And we've got a fragmented, inefficient delivery system. So they're there. They were there in 1974. I think the issue is there, and it needs to be addressed. And we can't ignore the fact that as we address them, there is not only the question of costs. In all of this is also the question of rationing. Saturday morning, Judy and I will be on a plane going to Seattle to attend the funeral of her niece, Lori. Lori was 47 years old and passed away just last week. She had breast cancer, identified a little over 10 years ago, had a vasectomy. Did not keep up with maybe going to the doctor as much after that to check whether it was all gone. And 4 years ago, had great pains in her back. Went to the doctor, and they found cancer all over her body, in her bones. They had to do some major surgery on her spine, relieved her of her pain. For the last 4 years, Lori has lived a unique quality of life. There has been quality of life because there has been expert treatment and care by doctors who want her to live, not die. By doctors who want her to care for her 2 children. By doctors who want to treat her as a person created in the image and likeness of God, with value and worth. Not just a statistic. She's been able to accomplish a lot of things in the last 4 years, especially with her kids. Especially her oldest daughter, who's got some problems. If Lori was anywhere else in this world, in a national health system, she'd be dead in 6 months. Thousands and thousands of dollars have been spent on Lori. Her husband is employed. Most of it comes through his insurance company. Four years have been very valuable to Lori and to her family. But the destination, the result, was known when the diagnosis was made 4 years ago. Now, the doctors were nice at that time. As they looked at it, they said, when they finished, they said, "This is remarkable." So Lori is not only part of the high cost, but also she's a bad result. She died at 48. She's a negative on life expectancy. All the way around, as far as measuring health care, she's a loser. But is she a loser? And how do we handle this? Because we have all of the innovation, all of the technology to deliver super care, more than anywhere else in the world. But it doesn't add up to a result that we want to measure. Is it important? I would think most of you would say it is. Now, let me just close my remarks. I hope we get some questions here, just to talk to you a little bit about what your hospital is doing in Central DuPage. Over this past 7-8 year period, it has transformed itself from a community hospital to a regional medical center, delivering tertiary services in certain select service lines. It has received ratings from Thomson Reuters, top 100 hospitals for 4 straight years in their top 100 hospitals in the country. High Grades, which is another rating of hospitals, has ranked CDH in the top 5% nationally for clinical excellence and patient safety. Magnet, the highest rating you can get for nursing care, was just awarded to CDH in the last year. And it has achieved a 90 percentile rating in patient satisfaction, physician satisfaction, and employee satisfaction. All of this has been accomplished through concentrated efforts of saying, how do we transform ourselves to deliver care and to do it in an efficient and effective way? Now, the objective to deliver tertiary care in this area could only be done if we, first of all, develop some partnerships. Cleveland Clinic and the Heart is an example of it. In neurosciences, there wasn't that partnership. So CDH hired top neuroscience in stroke and other areas, and have developed its expertise there. In pediatrics, we developed a partnership with Children's Memorial. In orthopedics, we had already reached a level of in-house expertise. The 3rd largest orthopedic program in the state, and ranked 35th in the nation by U.S. World in Report. Cancer care is just the most recent area, and I encourage you to go out and see our cancer center out on I-88, which includes not only the latest in treatment in radiation and equipment, but also the proton beam, which is a special treatment for cancer care that is only available in 7 areas in this entire country. There's only 7 of them operational. And this was the first one in Chicago. But these innovative programs, that many of which have been developed with these partnerships, really basically says, we're here, we're close to a population group, we can become a channel of distribution for you, Children's Memorial, or for you, Cleveland Clinic, to take your expertise and deliver it in our area through our vehicle. You're a winner, we're a winner. It helps you to increase your volume. You multiply your expertise through our delivery system. That's a leverage factor. That's a leverage factor. We need more leverage factors in healthcare. We need more examples of how resources, both knowledge resources as well as physical resources, can be leveraged. Important for us as we develop this to build a large and aligned physical platform for physicians and include more physicians in our employ. Employing now over 130 physicians in expertise, but primarily in primary care. Building scale in the delivery of health care, which is reflected in our recent announcement with the merger with Delnor Hospital, and expanding the community of care to the west. All of those things provide for vehicles to be more efficient, be more effective in the delivery of health care, and our initiatives being made by a caregiver. We need more of those kinds of initiatives across the country. We need some incentives that encourage providers to look at the delivery system and say, how can we be more effective? How can we be more efficient? How can we be more caring? So that's the summary of healthcare from my perspective. And so I'm here to take any questions. And if they get too difficult, I've got Jim Spear in the back, and I'll throw them back to him. So what questions? Yes, sir.
Supposedly hidden in the healthcare bill, there's a provision of taxing all transactions on money accounts, whether they be deposit or savings or just inquiries. Can you elaborate on that being part of the tax to quote help finance?
Yeah. Well, that primary taxing provision is for what is commonly referred to as passive income. For those of us that are on a salary, we are already paying a tax for Medicare. But for those of us that are living on dividends, interests from bank accounts or otherwise, we don't pay a tax on that income. This will tax that income for Medicare, just like it was a salary.
So is the tax based on transactions the individual makes?
It can be based on capital gains as well as on as well as dividends and interest income. Yeah. Yes.
We have a microphone. So
okay.
we can, let Alice
Good.
know. She'll come and,
looks like we've got some students asking questions too. Great.
Can you touch on kind of malpractice costs and the feasibility of tort reform as an effective cost-reducing measure?
Well, we need tort reform. It is an inhibitive, inefficient, and effective care. If you were a doctor and you had a difficult case to diagnose, you would take the extra test because you know that somebody's going to look over your shoulder and file a lawsuit if something goes wrong. So we need tort reform. We need limits, I think. We have it in some others areas. For example, we've had a long history of practice of limits in workers' compensation. So I think we've got a pattern which we could follow. We have a very strong lobbying group in the trial attorneys. And that's been the roadblock so far in getting anything effective done. Yeah.
I've had some doctors say that they, because of the rising cost of malpractice insurance and other burdens placed on them by the new healthcare legislation, that they don't plan to stay in practice. Does the population of available doctors and health professionals, is that of any concern to you?
Yeah, it is a concern. I don't have recent statistics, but I do have some statistics of 6-7 years ago when in states, especially in California and Florida, there were a significant number of doctors who left the practice. The reason I know about it is I served on the board of an insurance company that was the recipient of disability claims as a result of that. So there has been that phenomenon occurring. I don't have any current statistics on it, though. Yes, here.
You talked about retail pricing and the ineffectiveness of that structure. So why does CDH maintain a retail pricing structure if it doesn't work? Why can't I come in and prepay at the insurance rate and probably save money on the whole process of payments? Why does the system maintain that practice?
The system maintains it because the process of negotiating the discount today with the insurance company pre-assumes that you have a price to discount from. So that's what keeps it in the system. The disparity between our net revenue and our gross revenue is growing to such a degree, and the inability to understand our bills is confusing that we are taking a hard look at it, aren't we, Jim? Yes. So I mean, we're aware of it, but it's a real toughie.
Would you say that it was fair would it be fair to say that a hospital such as CDH makes up some of the cost of the 80% shortfall with Medicaid and Medicare with paying customers, people who
Yeah.
may get a reduction retail price, but the actual cost of an item may be still
Yep.
400% markup?
Yep, yep,
Yeah.
yep. You're paying for it. Yep. It's
So-
a transfer. It's a transfer tax. It's going on. I mean, and you know, we're not for profit, so we're not out throwing it away. It's not going into dividends to shareholders.
Sure.
It's going into our capital structure. But we have AA ratings at CDH. I guess, Jim, one of maybe 3 hospitals in the Chicago area that has AA ratings. We wouldn't have AA ratings if we were not financially sound. But one of the challenges today is, especially in hospitals in major cities, is their Medicare mix, their payer mix, is moving over that 50% line. And if that's happening to them, and they're also a teaching hospital with the added cost of teaching, they're quickly in a loss position.
I'm actually a nurse at Children's Memorial in Chicago.
Okay.
And I know that our payer mix in the last 10 years we're upwards to 60% or higher of non-paying customers, and just having a hard time staying afloat because
Yep.
of the things you mentioned. We're
Yep.
a teaching hospital, and these partnerships with Central DuPage we very much appreciate. So.
Yeah, yeah, yeah. Thank you. Yes.
Where would you begin to try to make ethical decisions to help limit and help guide an end to treating the chronic zombie patients? I work in healthcare at different hospitals, including CDH, and as I go closer to the city, there are kind of like pitfalls of facilities that just are kind of like incubators for zombie land, you know, like vent hospitals, chronic long-term care facilities that, you know, CDH is glad to get out of their ICUs that are problematic and get them into a long-term care facility. And then at these long-term care facilities, they linger for long periods of time, just incubating lots of germs that you don't want to know about, and it's kind of gross. But it is a major impact, I'm sure, on our deficit, but it's like, where can we go with, or where can we begin to start talking ethics?
Well, that's the ethics of preserving life or rationing life, isn't it? That's the ethic of who's going to make the decision about who shall live. And I wish I had an answer to that. I don't have an answer to that. I'm sorry, I don't have an answer to that. I think almost every major universal health system is in fact a rationing system. I think there's elements of our system today that is rationing. We're rationing against the poorer population in the country today. So we're rationing today. If you were 70 years old and you needed kidney dialysis, is it worth it? When there are 50 people behind you who are 50 and younger who need it, and you can only serve 20 people? Or do you say you're just too old? I was in a situation where I had an illness that had some options to it as far as treatment, and one of the options was surgery. I was over 70 years old, and I knew enough about healthcare, so I was aggressive in my exploring alternatives. At least 3 of the physicians that I saw concluded I was too old for surgery. So, you know, age is a factor and will be an increasing factor as far as how much health care is delivered. That's a reality. That's a rationing factor. Yes, George.
Central DuPage Hospital has done exceedingly well financially. You just indicated they have an AA rating. I remember reading in the newspaper an interview with President McGinnis. Is he president or chairman, whatever?
He's president and chief executive officer,
yeah,
right.
Mr. McGinnis. And the reporter said, Mr. McGinnis, how are you going to pay for this proton development and this oncology building, millions of dollars in these difficult times? He says, we'll pay cash. My question to you is about how long is this going to continue with the baby boomers coming up and approaching this 50% point that you talked about?
Okay. Well, let's take the proton beam for an example, George. It's another one of what I think, and Jim Spear had a lot to do with this because he was the architect that put it together. But it was one of our, again, I think, innovative ways of doing it. The major capital for the proton beam, which is over $200 million, has been financed and capitalized by a for-profit company using the public markets for the raising of capital. Our portion in that is a minority portion as far as capital is concerned, but is a majority as far as the delivery of care. So, I mean, that's using a for-profit model, using access to the capital markets of a for-profit entity for the capital needed to do it, in partnership with a not-for-profit entity delivering the care. So it's not, it doesn't happen just because we've got money in our pocket. We don't have enough, we didn't have enough money in our pocket for that one. We wouldn't have been AA if we had done that one. So it means that it represents a real live case of innovation, both in structure and in direction, and saying this is the right thing to do. Chicago should have a proton beam. We shouldn't be sitting here in Chicago without proton beam therapy for cancer treatment. And how do we do it?
Yeah, we want all those things, but we don't want to pay for it.
That's right, but we have to. And we didn't go to the federal government for it, and nobody paid taxes on it.
What's the situation on the oncology building situation where people are with cancer can get any kind of care they need except hospitalization?
Yeah, that's a facility that's designed for outpatient chronic treatment, the treatments of radiation therapy for cancer. And that was a capital investment of CDH. But that was all done in partnership. But the major capital requirement there was the actual machine of the proton beam. Yeah. I think I'm right, Jim, right on all that?
Yes, you are.
Okay, yes.
Thank you for the great job you did in explaining the complex and complicated system that we're in. And I've practiced medicine for 32 years in the area of radiology and nuclear medicine.
Okay.
Retired 8 years ago.
Hmm.
And I think the system is so complicated that it almost takes an incremental approach. By that I mean, I have friends in OB-GYN who haven't paid themselves in a one doctor practice for several months. They paid their bills for rental and in a very active service.
Yeah.
I have friends who are making less than a truck driver in family practice, $100,000
Right.
a year. And
So in medical school, it starts off with the star and the American dream of specialization. That's the lucrative area. That's where
Right.
pre-med students want to
Right.
get into. That's where you can make a big impact.
Yeah.
And now it seems like not only is it start medical school, and probably before, even now in practice of hospitals, they have hospitalists, intensivists,
Yep.
so that a physician loses his patient. Hopefully there's some communication between the two. I mean, it is so complex and so difficult to understand. I have a friend who read all 1,000 pages of the government's health care. And he's an insurance expert.
Yeah.
He was Health First chief and CEO and president. And he says that it's a total disaster. Now
It
I'm
is.
taking his word for it.
Yeah.
That's what he did for most of his life. What's wrong with the incremental approach? Getting the best brains in this country and hitting one area, whether it's delivery, whether it's access, whether it's quality of care, whether it's whatever it is a very complicated, and I think you did a great job, I really do. In one single session, you brought out so many things that, but it can almost be a source of hopelessness in the solution.
Yeah. And I was afraid about casting hopelessness, especially for the young students here who are thinking of going either thinking about being doctors or somehow in healthcare. And thank you for that last comment especially, because I wanted to remind everywhere, you got to recognize that I basically come from a business background. But there is nothing out there that has the built-in demand factor like healthcare. So what we need to do is figure out how to respond to that demand in an efficient and effective way. I mean, there's nothing you can make if you wanted to be in manufacturing. There's nothing you could make if you wanted to be in some other kind of service that has a constant, consistent demand factor from the human side like healthcare. People want their health, and they'll do almost anything to get their health. So with that demand factor, I think the only way to solve it is incrementally. The issue that I am perplexed about is what is the role of government and what is the role of the private sector in reaching those incremental results. And it seems like everything that we can examine that the government has touched with respect to health care is inefficient and ineffective. If I start out with health care to the Indians, it's that way. If I look at health care to the veterans, and they've been in those businesses for a long, long time, it's that way. If I look at Medicare, it's that way. So, I mean, I'd like to see a shining example of government doing it right, but I don't see it because there's many elements where we need government in order to get this done on a some elements on a universal basis. And we do have a coverage gap that we've got to address. So that's my dilemma.